Welcome to the deep dive. Today, we're going to be getting into the engine room of the human body, really, the reproductive system. And this isn't just anatomy for anatomy's sake. It's absolutely foundational if you're studying pharmacology.
It really is.
Because pretty much any drug that involves sex hormones, contraceptives, cancer treatments, you name it, it all hinges on understanding the core mechanics we're about to map out.
That's our mission today, really, to be crystal clear on the hypothalamus, pituitary gonadal axis, the HPG axis. That's the command center.
Right.
So our goal is to just pull out the essential structures, map the hormone flow, and really detail the specific effects of estrogen, progesterone, and testosterone, because those effects are exactly what our drugs are going to target.
And before we get into male versus female, let's start with something that I found pretty surprising, the common ground.
Yeah.
I mean, you look at the two systems and they seem totally different, but the source material really emphasizes that both systems actually start from the same fetal cells.
It's such a crucial point. It reminds you they're functionally linked. The ovaries and the testes, they are both sexual glands, and they respond to the exact same hormones from the anterior pituitary.
FSH and LH.
Follicle-stimulating hormone and luteinizing hormone. The very same signals.
So if those are the signals, then the master switch has to be that HPG axis itself. Can you just walk us through that sequence one more time? Because it really does govern everything else.
Certainly. So think of it like a three-part cascade. It starts up high in the hypothalamus. It releases something called GnRH, gonadotropin-releasing hormone.
Okay.
That GnRH then travels to the anterior pituitary and tells it to release FSH and LH. And this whole switch, which is basically silent all through childhood, it flips on at puberty.
Why then?
Because the hypothalamus just loses its sensitivity to the androgens that were keeping it quiet. And that's what kicks off the whole process of sexual development.
All right, let's turn to the female system first then. You've got the ovaries, which are basically the storage units for the ova. And the key fact here, which is just wild, is that females are born with all the ovas they will ever have. No new ones are made after birth.
And they're stored very strategically. Each ovum is held inside a follicle. And what's remarkable is that the follicle isn't just a container.
It's more than that.
Oh, yeah. The follicle itself acts as a temporary endocrine gland. It's designed to flood the body with estrogen and progesterone to get everything ready for a potential pregnancy.
So the ovum then travels through the fallopian tubes, which have this ciliated lining that kind of pushes it along.
Right, it propels it toward the uterus.
Yeah.
And the uterus is where the blood-filled endometrium develops, waiting for implantation.
Okay, let's talk hormones. Estrogen.
Estrogen is huge.
Yeah.
Its effects are so widespread because it's a steroid hormone. That means it can actually go inside the cell, bind to receptors there, and directly change cellular activity through mRNA.
So when we look at the list of effects in the source material, what are the most critical takeaways for someone who needs to understand the pharmacology?
I'd say you have to prioritize two things that have massive clinical implications. First, estrogen increases high-density lipoprotein. That's the good cholesterol.
So it's protective for the heart.
It offers natural protection against heart disease, yes. And second, and this is critical, it inhibits calcium resorption from the bones.
Ah, so that's the osteoporosis connection.
That's it. The moment that protection is lost at menopause, the risk for osteoporosis skyrockets. And entire classes of drugs are designed just to mimic that one effect.
That's a great connection. It's not just that it helps bones, it's how it helps, and that's the drug target. What about some of the other effects?
Well, estrogen also causes the body to retain sodium and water. This is thought to increase plasma volume, creating a bigger reservoir of fluid for nutrient exchange with the placenta.
I see.
And finally, it has an anti-insulin effect. This is strategic. It ensures there's plenty of glucose available for a developing fetus.
Okay, so moving to progesterone. If estrogen is the developer, progesterone is the great supporter, released after ovulation.
Progesterone is like the body's security system for the uterus. It locks things down. Its number one effect is decreased uterine motility.
It calms the uterus down.
It has to. It's absolutely essential to stop the muscular uterus from contracting and expelling a fertilized egg. It allows for implantation.
And it also prepares the environment itself, right?
It does. It helps create what's called the secretory endometrium, which just means making the uterine lining super rich in glucose and blood supply. Plus, it causes the cervical mucus to thicken, which physically blocks pathogens from getting in.
A little shield.
Exactly. And the most commonly observed effect is the slight increase in body temperature it causes. This is the whole basis for the rhythm method of birth control. That temperature spike tells you ovulation just happened.
So let's connect all this. How does this precise, 28-day cycle actually work? How does it all get timed out?
It all kicks off with FSH and LH, stimulating the ovarian follicles to grow. As they grow, they release estrogen. Now, here's the key pivot point. When estrogen levels get high enough, they suddenly flip from being a negative feedback signal to a positive one. And that triggers a massive, sharp release of LH.
The LH surge.
The LH surge. That's the literal trigger for the egg to be released.
So the surge causes the follicle to rupture.
That's ovulation.
Yeah.
And the shell that's left behind, the ruptured follicle, it transforms into something called the corpus luteum.
And that's another gland.
It's a temporary endocrine gland that just pumps out high levels of estrogen and progesterone for about 10 to 14 days.
And this is where the negative feedback loop comes back in to pause everything.
Precisely. Those high EMP levels tell the hypothalamus to stop sending out GnRH, which stops the FSH and LH. The whole system hits pause.
And if there's no pregnancy?
The corpus luteum shrinks. EMP levels just plummet. And that crash does two things. One, the uterine lining slows off, that's menstruation. And two, the brake is released on the hypothalamus, so GnRH, FSH, and LH all start up again.
And the cramps people feel.
That's prostaglandins. They're the agents that stimulate the uterine contractions to shed that lining.
So that's the clockwork of it all. But the whole thing is run by the hypothalamus, which is in the brain, so external factors can mess with it, right?
Oh, absolutely. The system is designed to save energy. So high stress, starvation, extreme exercise, anything like that can just shut down GnRH release.
The body's basically saying, not a good time for a baby.
Exactly. Survival over reproduction. And on a lighter note, light itself has an influence.
Really?
Yeah, increased light levels, like you'd get moving closer to the equator, are associated with a boost in FSH and LH, which might contribute to earlier puberty.
That's fascinating. Okay, so just briefly on life cycle changes. Pregnancy is maintained by HCG, and then we hit menopause.
Right. Menopause is just when the supply of ova runs out. The ovaries stop responding, and we lose those protective estrogen effects, like the calcium retention.
Okay, let's pivot now to the male system. The testes are the main glands, and they've descended into the scrotum to stay cool.
That cooler temperature is crucial for sperm production. And the testes really do two separate jobs. You've got the seminiferous tubules, which make sperm in response to FSH.
And the other part?
The interstitial, or Leydig cells. They produce testosterone in response to LH. So FSH for sperm, LH for testosterone.
And testosterone is the big one here. It affects growth, metabolism.
Just like estrogen, it works by getting inside the cell and affecting mRNA. Let's focus on the two effects most relevant for general health and pharmacology.
Okay.
Testosterone increases protein anabolism, which is building up, and decreases catabolism, or breaking down. That's the basis for larger muscles.
Makes sense.
And second, maybe less known, it increases hematocrit. That means more red blood cells, which means more oxygen carrying capacity.
Those two things alone explain so much about physique and endurance. What about the other, more obvious effects?
Well, you have the thickening of vocal cords and skin, growth of male accessory organs,
Right.
and there's a key clinical note here.
What's...
If the testes are lost before puberty, a person needs replacement therapy to develop. But if it happens after puberty, the adrenal glands often produce enough androgens to maintain those secondary characteristics.
I see. Now, the control mechanism. Why is the male system continuous, not cyclical?
It's a really beautiful, simple, continuous feedback loop. FSH stimulates sperm production.
Right.
But alongside the sperm, the cells also make a substance called inhibin.
Inhibin. I've heard of this.
It's an estrogen-like substance that sends negative feedback specifically to decrease FSH. It prevents the overproduction of sperm.
And that's interesting because it's a potential target for male birth control, right?
Yeah.
Because it doesn't mess with testosterone.
Exactly right. Meanwhile, LH stimulates testosterone production, and the testosterone level itself provides the negative feedback to shut down GnRH and LH. It's just a steady, self-regulating system.
And does light affect men too?
It does. The sources note that increased light exposure, spring fever, has been shown to increase testosterone levels in men as well.
And finally, a parallel to menopause, andropause.
It's also called the male climacteric. It's just the age-related decline in testosterone effects as the cells in the testes gradually atrophy. It's a similar process, just usually more gradual than menopause.
Okay, let's wrap this all up with the human sexual response. The sources point out something I didn't know. Humans and ferrets are unique in that they're sexually responsive at will, not tied to an estrous cycle.
It's true. And The response goes through 4 phases: stimulation, plateau, climax, and resolution.
Right.
And here's the major nursing and pharmacology consideration you have to take away from this entire deep dive.
Okay, I'm listening.
The climax phase results from massive stimulation of the sympathetic nervous system.
The fight or flight system. So that means increased heart rate, blood pressure, sweating.
And glycogenolysis, breaking down stored sugar for a burst of energy.
Uh,
And this is the critical clinical link. Any drug or disease that interferes with the sympathetic response, think of a patient on a beta blocker for high blood pressure, will inherently alter that patient's ability to experience a sexual response.
so you have to educate them about that.
You absolutely have to. Otherwise, they might stop taking a life-saving medication because of an unexpected, and to them, unexplained side effect.
What an impactful way to end. So we've covered the HPG axis, the negative feedback loops, and the specific jobs of estrogen, progesterone, and testosterone.
And if you just think about recovery, say, postpartum or during menopause, remember, these hormones are working deep inside the cell, changing mRNA activity. They are literally changing how cells function.
That explains why it's not a quick fix.
It's why the body's return to homeostasis takes weeks, sometimes months. It's reversing deep intracellular changes.
That is a profound way to think about it. Before we sign off, here's a provocative thought for you to chew on. We know that external factors like stress and light have these documented effects on GnRH release. So what impact do our modern, highly regulated sleep patterns, our chronic low-grade stress, and our year-round indoor environments have on the subtle individual variations in hormone cycling that might be clinically significant, but just, go unnoticed?
Something to definitely ponder as you look at your future patients.
Use this deep dive as a really strong foundation for all the pharmacology to come. You are now well informed on the fundamentals.